Well, thank you very much. Thank you everybody being here and online. It's always a pleasure to be here in Grand Rounds, invited by Dr. De La Hoz and everybody here at the school. So we're going to talk a little bit about ergonomics at the beginning. Most of us know what ergonomics is, and then we're going to do a deep dive on what do we mean by clinical or occupational ergonomics. Most of us know what ergonomics is, but through the years, doing this for almost 2 decades, every time I go to a place to do an intervention or to some sort of a workplace assessment, the first thing everybody thinks about, okay, here's the guy who's going to change my chair. So I call it a chairologist, so of course it's, making it a little bit fun. But the fact of the matter is that it's a more complex and broad discipline. It actually branched off engineering, but the main focus of the definition from the International Ergonomics Association is, optimizing human well-being and the overall system performance. So what does this really mean? It means that, the interaction between a worker, the workplace, and the environment is kind of, we can see it as a system if you see it in an engineering's perspective. But, we're going to focus more on the clinical part. Ergonomics can go from macroergonomics to microergonomics. We have ergonomists doing cognitive ergonomics, studying human error, designing tools, designing airplane cockpits, you name it, it's everywhere. We have ergonomists designing phones, but everything is focused on the person because it's an anthropocentric discipline. In other words, we focus on the person. And of course, we have cognitive factors, physical factors, and organizational factors that influence, how we see workplaces and all of this. And when we talk about musculoskeletal diseases, we're gonna see why this is so relevant. Industry has been evolving through the years. Literature calls it from industry 1.0 to 5.0. The message on this slide is in the past 20 years, technology and work has changed very rapidly. So we have to kind of keep up with that change. Very different than in the first 200 years, or 300 years. And then we can also see it as stages. Us that do occupational health, occupational medicine, ergonomics, or any of the disciplines within occupational health, have been understanding historically how these stages have changed. We've gone from pure manual labor to, with all that entails occupationally wise, to the future, which is, mentally directed interfaces and anticipation with AI. And we have to also, of course, be cognizant of this when it comes to studying workplaces and creating preventive interventions. Historically, we've also understood that although it's not explicitly mentioned in different agencies and health agencies around the world, work is a social determinant of health. We know that social determinants of health are the conditions which people are born, grow, live, work. But most of these domains that are mentioned everywhere in the literature, none of them mention work. But if you think about it, work is implicit in all of them, directly or indirectly. Especially in societies like ours, where the healthcare and healthcare accessibility is linked to your job. Very different than other countries, with just a human right. But it becomes like a blunt social determinant of health when it comes to work-relatedness. I've dedicated my whole career on vulnerability of, all types of vulnerable exposures and workers, intrinsically or extrinsically, and we've studied the social determinant aspect of it very much, and we've been coining the 4D job term, which is the previous 3D job, which focused more on the physical biomechanical exposure, just to acknowledge all the social determinants and of health of these exposures of workers that do vulnerable jobs. So with that being said, when we talk about work-related musculoskeletal disorders, we know the epidemiology. We know how prevalent it is. We're talking about approximately $192 billion of expenditure a year. 7,123 approximately non-fatal injuries every day, and these are only the reported within the private industry. We're not even talking about here non-private industry or vulnerable workers like informal workers and all of this. This data it's a little dated, but it's still relevant. This comes from the Department of Population Health, which is the agency that funds our program. And they identify for many years, the ergonomics factors is always very prevalent in different industries. Of course, they change within the industry itself as well. When we talk about healthcare, healthcare is very large, so depending on what you do within healthcare, musculoskeletal issues can become more or less prevalent. So what are the ergonomic hazards? The ergonomic hazards, they're biomechanical, but most of them, but at the same time, you can also have ergonomic hazards that are around the environment. Or we can also talk about the psychosocial risk factors of the exposure and how does that affect the musculoskeletal system. And we have the conventional, the typical exposures, which are forced exposure, repetition, contact stress, and environmental conditions, which can also be a combination of many of them. Very, very, very seldom we have one exposure. It's usually a combination of both, of some. And then at the same time, we see that these environments, they interact with each other. So you have the personal aspects of the exposures, you have the psychosocial aspect of the exposure, and the physical. And we've learned that also the organizational factors, which is something that we're going to talk about a little bit more, have a direct impact on the person and direct impact in the outcome. And of course, it can translate on chronic pain, musculoskeletal-wise, as the exposure goes on. And we've been learning, and the evidence and the literature has been showing us more and more evidence that psychosocial risk factors are also playing a big role into the ergonomic exposures and how it exacerbates all the conditions within a work environment. High levels of cortisol, constant levels of cortisol with constant stress in the workplace creates a vicious cycle where you do an intervention, for example, physically or biomechanically, and then you have high levels of cortisol permanently, and then that creates a cycle that needs to be addressed and not put aside or undermined. All right, so when we talk about occupational medicine and ergonomics, I kind of try to see it very on a more, it's more complex, but in a simplistic way. In occupational medicine, we focus on the person, so the person is our patient. It's that we are focused on the person that comes in with a disease or an illness that is caused by work. And when I take off my occupational physician hat and I put my ergonomist hat, then my patient is the workplace. So that's who is sick. The workplace is sick, and I need to address the illness in the workplace. Thinking about it more clinically. So, but of course, they're all related. They are related, intimately related with each other. What we want to do with this clinical ergonomics approach is, we want to go into primary prevention. Unfortunately, a lot of the things we do is secondary, tertiary prevention, which is okay, but we want to focus on the primary prevention part. When we do a lot of ergonomic interventions, we tend to always redesign workplaces because everything's already set up, but they're not set up in a way that adapt to the humans that interact with the workplaces. So this is kind of like our goal. And of course, we always try to do prevention through design. This is a proposal that we've been using for many years from our beloved NIOSH. And we want to create the best interventions when it comes to how do we minimize these risk factors in the workplaces the most. So you want to eliminate, substitute, or go down the inverted pyramid, or you want to do a combination of some of them. Now, when we do prevention through design, as clinicians, we know that humans have limitations. When it comes to biomechanics, you have limitations that interact with the workplace. So if you see and if you assess a workplace or a work task, and you see that people are going beyond their limitation, then it's going to translate into a problem. It seems very simple, but it's really not. When you go to workplace and start walking around, and seeing the exposure, you see it's more common than not. There are different guidelines around the world. Here in the U.S., unfortunately, we have not as many as we would like to, but there are some. We have manual material handling guidelines, limitations, push and pull, how much can you push, how much can you carry. So these are things that are very well established in the literature, and we as clinicians, need to know these things, because when we try to create, we try to determine causation, we have to know where is it coming from. The anthropometrics part is also very important. I mean, everybody's shaped different, and when you adapt workplaces to people, you have to, be mindful of these things. If you're very tall, or you're not as tall, or if you're, wide, your hand reach, your arm reach, if you're working above shoulder level, or if you're working on the knee level. So all these things are very important when it comes to determining causation of musculoskeletal issues. Now we can actually design to bodies that are changing time. For example, pregnant workers. Their anthropometrics changes weekly. So we created this ergonomics evaluation unit, which has been functioning for some time now. Back in 2017, we saw the need of creating an ergonomics program with a more population health approach and not focus on the workplace. So we wanted to do population health, which is what we really should do, thinking about not the individual patient, but how can we impact people and groups of workers. So, we started doing community outreach, population-oriented ergonomic training programs. We have decades of interactions with community-based organizations, basically treating and helping the most vulnerable workers in the city, along with the health and hospital system. We started doing in-person workplace assessment, which was, really good. But then, we also encountered the historic difficulty that we have as accessing workplaces. So, I mean, if you go to other countries, it's easier to go into workplaces. There's a historic aspect here in the U.S. That it's very hard to get into workplaces, especially workplaces that are small areas to work. Like mom and pop shop in the corner, the hardware store in the other corner, the nail salon. So it's very challenging. So we created this model where we actually simulate what workers do at the lab when we can have the access to workplaces. So that way we can create the clinical occupational ergonomic reports for the physician when it's needed with a more objective manner. And I'll talk about it later. So right now, we have, since 2023, we have a JCO compliant unit, which we do clinical ergonomics, workplace assessments, we do simulations, and we do workplace assessment in person and remotely. That's something that obviously triggered after COVID, and we're pursuing some research initiatives as we speak. More descriptive, the clinical ergonomics, we create clinical reports, patient care protocol, and also we have the Joint Commission compliance to actually see patients. And like I said, there's a whole program we run a whole program for workplace assessment and interventions, ergonomic training programs, and very important, the participatory community-based programs, which we have this interaction with most of the community-based organizations around the city and nationally as well. So when we talk about the ergonomic simulation unit, there are things that we can do and are very important that generate reports that make it more objective when the occupational physician or the clinician sees the patient. So we can do population studies in anthropometrics. We can do workplace simulations and design. We have work hardening systems. We have all these equipments and resources that we can mimic and simulate as accurate as possible in the workplace remotely if we don't have access to the workplace. But of course, it's important to understand that the gold standard is to go to the workplace. But these are resources that we offer the working population in New York City, especially the most vulnerable one that come to health and hospitals, so that they can have some type of service so they can improve their workplaces and what they do at work. We've created a whole protocol and matrix where you can, I mean, my idea is not for you to read all this, but the message of these 3 slides is that we've identified, all the musculoskeletal occupational conditions. The first 3 columns are common for work-related and non-work-related, but we also identify the exact biomechanical exposure depending on the workplace that they're exposed to, and the recommended assessment tool for it. So these are all, I don't know if I know people know what the ergonomic assessment tools are, but there are many assessment tools. There are hundreds of them, but some of them are more validated than others. So we choose, the ergonomic assessment tools that are most accurate and validated in the literature to actually assess the level of risk factor, or the level of exposure that the person has when it comes to a certain task or whatever they do at work. So, for example, you have if you dedicate your work on office ergonomics, for example, there's a specific assessment tool, the Rapid Office Strain Assessment tool. If you do hand activity level, there's a specific assessment tool for that. If you do manual material handling, if you do push-pull, and so forth. If it's a postural exposure, if you work, on prolonged standing or prolonged sitting. So these are tools that we have that are out there, but we've organized them in a way that can be actually very accurate and can generate a report as objective as possible when you have the patient in front of you. That's basically the main point of this. So these are just, all the musculoskeletal conditions that we all know about, but they are very well specified and protocoled in the process. All right, so when we talk about interventions, like I said on my first slide, the first thing people, when people, not people that are experts on this, but the first thing that comes to mind is like, here's the person that's going to change my chair. But when you talk about ergonomics, but when you go to, for example, the IAA website, these are all the technical committees that are within the Ergonomic Association, the International Ergonomics Association, and the human factors. So U.S. human factors also has a lot of subgroups and stuff. So it can get as granular as informal work or visual ergonomics. You name it, cognitive ergonomics. So it gets very, very broad. And like I said, this is a engineering. It started from the engineering aspect of it. So, but we as clinicians, we want to make it more clinical for our patient care. And just to make it simple, we're going to divide it in 2 parts. Macro ergonomics and micro ergonomics. All right. So macro ergonomics, it's the organizational redesign of workplaces, rotations, night shifts, and all of this. So when problems are systemic, complex production system. We want to do an anthropometric study to see what are the sizes of the people in the workplace, and see why are they getting sick musculoskeletal-wise because of the interaction with the workplace. But our focus in this talk, and most ergonomists, dedicate their career is in microergonomics, which is more like workplace assessments, task assessments, biomechanical exposures per se. Environmental ergonomics. Environmental ergonomics is basically what's around you. So like when I go to a workplace, I have a luxometer, I have a sonometer, a sonometer, and I measure light, but not on a professional way because that's an industrial hygiene area, So, but you need to know these things when you're going to the workplace. As we all know, the musculoskeletal system reacts different when it's very hot and when it's very cold, So these are things that you need to kind of like understand that are around the area. So it's a very important part of ergonomics, but I always like to make the distinction that when we see that there's an environmental ergonomic program, we work synergistically with the industrial hygiene, which are actually the experts that have all the calibrated equipment and all of that. Cognitive ergonomics. It's just basically the interaction between the interface and your your brain. That's in summary what it is. Just picture a air traffic controller, for example. So it's very important that it's millimetric. If you can, there's no space for human error. So So these are things that we also do. Tool design, well, you can just imagine all types of tools from scissors to whatever tools we need. And what brings us today, which is the clinical ergonomics, occupational ergonomics, which is something that we've been developing and kind of trying to coin and disseminate, and I'll explain what's the importance. Okay, so I'm gonna give a brief example. Okay, so we're good in time. So I'm going to give a brief example on the microergonomic interventions, and then I'm going to focus on the clinical ergonomic part of it. So back in 2020, we had this issue around health and hospitals where we found at Bellevue Hospital, we found that we needed to address the manual decedent patient handling during the COVID pandemic. So we had many people passing away, and most of them initially were bariatric patients, and we had the same 3 people working in the morgue and the 4 poor people transporting the patients. So we all lived this through New York City. You know, we had 800 people, unfortunately, dying daily at some point. And then it was something that we implemented within the hospital system, and then we expanded it through the National Research Agenda NORA Musculoskeletal Council, which we're members of, and from our, I always say, my beloved NIOSH, right? And then it became a national thing, you know. So you know, it was a partnership from many organizations around the nation, and we basically what we did was an organizational macroergonomic intervention to prevent work-related diseases and injuries on mortuary patients that handle manual decedent handling. So we knew that, you know, the death toll was very, very important at that time. It correlated with the musculoskeletal issues. I'm just going to go quickly through these slides because it's just an example of a macroergonomic intervention. We understood that a lot of the good practices were in place for live patients to be handled, but there was basically nothing on decedent patients. So, and even less on a mass fatality situation. You know, so it was a very important, it was a very actually sad situation, but very important to address it. So we look at the differences between, you know, decedent and live patients. You know, there were environmental conditions, task frequencies, working populations, psychosocial stress, you name it. And then we started studying, you know, how we can transfer, move, push, pull, incline with this more ergonomics, clinically ergonomics mindset to it. And, you know, so, you know, we studied, you know, what was happening, what are the best ways to move these patients, and with respect and dignity, you know, considering the condition and the situation. And one of the things that actually we were more concerned was the BCPs, because they had to be sent to a body collection point, and which was not conventional, and I'll talk about it in the next slide. You know, also how to move the patients within an envelope zipper, and so forth. All right. So we studied every single task that was done from the point that the patient expired to the body collection point, right? Which we had all these refrigerated trucks outside of the hospitals, as we all remember, because they couldn't fit, they didn't fit in our areas. But then it created a problem because now, you know, how do you move these patients in there? So it was a systemic issue. Okay, so we studied every biomechanical exposure from every step of the way, and then there was, you know, a prevention through design intervention. So, you know, there was recommendations done. There were, you know, how to move these patients. You know, we started studying even, you know, how do we get these patients to the body collection points, and, you know, some proposals are being done. You know, hopefully these good practices will be published one day through NIOSH, hopefully, because this will help a lot of populations in the U.S. and the world. You know, so this is an example of how do you do a macroergonomic intervention. And, you know, for example, here, you know, we understood that that the bodies had to be stored in the middle aisles and not on the top nor the lower ones, because you want to avoid manual material handling above shoulder level or on the bottom. So this will be public at one point, but I did want to bring it up to you. Okay. Okay, so now let's go into a more microergonomic intervention. So I'm going to present the case. So these were 4 artists, with working dues, upper extremity issues, cervical issues, lumbar musculoskeletal issues that came into our clinics. And then, they were well educated. They had a specific knowledge as artists. It was an artisan type of job, so it was very, very well trained. And they were called metal prep associates, in New York City manufacturing. They worked 10 hours per day, only half an hour of lunch and 50 minutes break. All right. Main duties were, sanding the parts and tiny parts, and where they would hold it as in a pinch grip and so forth. So what we do is we had the opportunity to go into the workplace, and then we did all the ergonomic assessments, and we define all the biomechanical exposures specifically to what they were doing. If it was sanding, if it was metal prepping, if it was polishing, and a lot of the things that we saw was people. They were actually the main issues that they had was that they were utilizing the tools while their hand was suspended in the air, right? And you can also see it here. You can also see it here how how they were using tools suspended in the air while vibrating, and they had no arm support, right? So basically they would stand there for hours, and the exposure was evident, but they didn't have any other tools within the workplace to actually improve these exposures. So they had arm vibration, prolonged standing, sustained awkward posture, and so forth. You can also see it over here how the biomechanical exposure of the tool, while they had deviation of the medial deviation of the wrist, or they had lateral deviation of the wrist. So it was a very artisan way of doing the work. Although they had machinery, they were actually doing what they weren't supposed to do, which is adapting to the workplace. When we talk about ergonomics, it should be the other way around. You got to adapt the workplace to the people. But I mean, this is very common. This is not something that out of the ordinary. In fact, most places are like that. And then when we see a patient and comes to our consultation, these are things that are important for the clinician to know in order to see, to kind of like assess correctly and understand what's happening. So we had some recommendations. These recommendations, go for the employer, the employee, and the worker, of course. The worker, the employer, and the clinician as well. We're going to talk about it now. So recommendations. These are very general recommendations. You can tailor design these as necessary. So what through the years, we've developed a system where you want to rotate tasks, right? So for example, if you think about it, you want to rotate what they do from a more high demanding biomechanical exposure to a lower demanding biomechanical exposure, and then you can go back. The work has to be done, regardless. So you want to think about it when you do the intervention and recommendations. You want to think about how can I minimize the risk factor on a group, on a musculoskeletal group. For example, if I'm doing repetitive motion constantly, 8 hours a day, and maybe you want to change the task where you don't do like a flexor extension repetitive wrist motion, and then you use your left shoulder now. I'm just making an example. So that way you allow that risk to minimize the risk factor for a musculoskeletal issue and the fatigue, allow it to recover while you're still doing the work. So you want to reorganize the work in a way where you can, we call it movement economy. Some literature say movement economy, which is, you want to kind of like reorganize the way people move to prevent, the issue. A lot of time they ask me, so what's better, to work sitting or standing? Well, none. It's the alternating of the posture is really what's going to prevent you from having the problem. So it's a little bit of that, okay, or a lot of that actually. So of course, shortening the work days, shortening how they stand and so forth. And then we had also specific more workplace recommendations. Like adjust height, adjust of the work table, anti-fatigue mats. It's a job designed to. It was a job designed to be performed standing. So so if something's supposed to be performed standing, then you got to address the standing issue. So you can include anti-fatigue mats. You can include semi-standing chairs or semi-sitting chairs, depending how you see it. So these are chairs that are not meant for you to stand. They're not meant for you to sit. They're meant for you to work standing, but it allows you to kind of like change that posture and minimize the pressure in your lumbar, for example. All right. Implement a leg system where they don't have to be standing with their hand suspended. There was an initial proposal where we can use a kind of like a arm support, so they can have an arm support, and the arm support moves with you, and then it minimizes the shoulder strain. But when you make these recommendations in the workplace, you kind of have to be cognizant of how feasible it is, the investment. You really want the employer to do it. So you kind of like give recommendations, like this is the ideal, this is the next ideal, and this is like the minimum. So and then they're usually connected with cost, of course. So it's more expensive to change the whole thing to a leg system than to put an arm support. But you give them resources, and then you follow up. There was a huge issue with the way they would do work. Everything was done on pinch methods. So we try to transition the way they would do the work more into the grip. Of course, we have more. The hands has more strength when you grip than when you pinch. So these are things that seem trivial, but these are the reasons why they're knocking on our door with the work-related musculoskeletal injury. So these are not the reports from this case, but this is a snapshot of how the reports look. We want to have a short report where the clinician or any can just read it in 4 minutes, 5 minutes, just the same way you have an X-ray, you have a lab work. Well, you have the ergonomics report. When you have a patient. So what this does is it gives you the insight and the objectivity of what the person is really doing, and it gives you the tools and the resources clinically to improve the patient's patient care. So what can these reports or this approach that we call clinical occupational ergonomic reports? All right, so we're merging the occupational medicine philosophy and what we do with the ergonomics philosophy. So we make it a clinical. All right, so when we get a report like this, it can help the occupational physicians in an objective measurement of the physical exposure. So we want to know if it was just work related, was it aggravated by work, is it exacerbated by work? I mean, we're talking over here about musculoskeletal issues, of course, and then so it can be, or it has been very useful already, and it's been proven to be very useful, and patient care has been improving towards it. Treatment, this is probably the most, I'm not going to call it controversial, but the most, the pitch that I really if there's one slide that I want you to take from this whole presentation is this one, we're taught and we're trained that when you talk about treatment, we're talking about clinical treatment, like the patient has pain, or the patient has asthma, or the patient has this, right? Work-related. But we have to expand our approach to this and be a little bit more holistic, like what's happening at the workplace, it's part of the problem. It is the problem, actually. And then when we talk about treatment, the treatment of the workplace has to be part of the treatment. So when you talk about, well, how can ergonomics improve my treatment per se, then you click immediately on your clinical side. But if you think about it, we try to create the prevention and the workplace intervention as the treatment, because the person is going to go back to the same place they got injured. The reason why the person came and knocked on your door, it's back at work. So, so we're doing a disservice if you think about it, right? You're like, all right, the person is going to go back to the same place they got injured. So, so am I really doing what what I want to do for my patient? So it has to be seen more holistically. And you can argue that industrial hygienists can also use this principle as well, and so forth. But when it comes to musculoskeletal issues, it hurts. People come in with pain, and limitation. So so it's like an immediate thing that you need to address. You can also contribute to the patient's evolution, and improvement. You work together with the ergonomist clinically, just to see, is the person relocating? Where did the person relocate at work? Is the person relocating in a place where the exposure is similar, or are we actually doing a service and patient care wise? And an educational approach, on safe practices at work and away from work. So sometimes we see the clinical ergonomics aspect of it, that it not only within the workplace but also outside of work, and it's kind of like a lifestyle. When you go to the grocery store and then you have all these items, and then you're like, you want to buy a bag? Yeah, one please. So you buy only one bag, and then you have 20 pounds of stuff in one bag, in one arm. So you should have two, to kind of like balance, your weight. So these are simple things that go into the training for the workers to take home, and kind of it's like more like a lifestyle. And very important, safe return to work program. I mean, like I said, as with the clinical approach of the ergonomics program, we can contribute in determining the levels of impairment. Focusing on capabilities. A lot of times you say, well, I mean, what's the level of impairment? Well, the person can't, abduct the right shoulder more than 10 degrees. Fine, and that's a permanent limitation, But when the person goes back to work, the main question is, okay, well, what can the person do, right? It's like so we can be very helpful on that, because we understand what's the details of what the person does at work, and we learn all the tasks within their job, and then we can say, okay, listen, so the person cannot do from 1 to 10, they cannot do 1, 4, and 8, but the person can do this, and that. So you also give the opportunity for the employee to maintain their jobs and be productive and not exacerbate what they have. So of course, improving and redesigning workplace adapted to workers' capability, tailor recommendations for the treating occupational physicians, workers, and employer. We can have one report that everybody can read, right? Or we can make reports that are more tailored to the reader. For example, I mean, listen, we need a report for the working population. All right, so it's a more kind of like down to earth, not simplistic, but it has to say what it has to say, but in their own language, right? And we can have tailored reports also for the employer. That at the end is the same message, but it differs in the narrative. When the employer, you can give, all right, listen, you have to make this redesign and improvement in the workplace because productivity, return on investment, whatever you want to use, whatever the employer wants to hear, whatever they need to hear. And of course, to the physician with a more clinical and approach, all right? So And this is next to my last slide, but I wanted to give an example of a patient that we had. So we had a patient many years ago that came in. She would be chucking clams in some restaurants in New York. So that's all she did. She would chuck clams all day, and of course, she came in with all types of hand tendonitis, Deckervine, you name it. Her both hands actually, because she started using the other hand because the other one was the initial one that was already hurt. She was seen by a physician before she came to us, and she was given a recommendation to the workplace. She can't lift more than 5 pounds. So that was the recommendation from the physician that saw her first, which, by the way, was not an occupational physician, but she was seen by a physician. And then she goes back to her workplace and she gives this to the employer, and they're like, well, there's literally like nothing you can do here then because you can't lift. But then she comes to us, and then when you actually study the workplace and the task and everything, like the 5 pound lifting has nothing to do with her actually diagnosis and what we need to prevent. Her issue was pronosupination and force resistance of the clamp. It was a totally different thing, right? So actually, she could have lifted 5 pounds, and she could have kept her job. To be honest, it had nothing to do with with actually lifting. So it's kind of like the message is you focus on what the person can do, and the solution was like we looked at the tool, and it was a very thin blade. So it was of course recommendations by a mechanic and all of that, but if you would widen the blade, it would give her more force, and you would use less. You would need less force when you supinate, So these are things that we can be very helpful to the treating physician, to the employer, and of course to the workers. Fortunately, she lost her job, and then they couldn't find anything for her to do, and yeah, these are the things we want to avoid. Okay. And this slide had some arrows. I don't know what happened, but anyway, so it starts here, and then it goes around here. Okay, so just picture the arrows. All right. So we have a work-related musculoskeletal issue. People come in, and workers come in, and we do our clinical assessment. Then we have our work. Then we do our workplace ergonomic assessment. We understand deeply what's happening. Then we have, of course, the clinical treatment and rehabilitation. Then we have the workplace treatment and ergonomic intervention. And then after that, we want to do training and preventive education. And ultimately, we want to understand after the person reaches maximum medical improvement, what are the levels of impairment, what the person can do, and then a safe return to work. Safe is very important. When you see the literature, it's a lot of return to work publications, but sometimes they're missing the safe work. So, but then when they return to work, we've already done this. We've already done this. We've already done this. So they're going back to a safer place. And I guess the last message would be that here it has a clinical single patient approach. Because you want the person to go back to a safe place and be productive. But honestly, that person can be there today. You can be there tomorrow. I can be there in the same workplace. So we're actually doing an occupational population health intervention. Because when you improve the workplace, anyone who rotates through it would have better working conditions, right? And then we do a better service for our patients. And that's what I have for you. Thank you so much.